Hello, everyone. Welcome to the Road to Recovery podcast. This podcast is a platform for education, discussion, and conversations on mental health. I'm your host, Amira Shah, and in this podcast, you'll get to know more about the therapeutic process, insight into life from the perspective of the psyche, and also join me in exploring current issues with other practitioners. I specialize in grief, but I'm always interested in learning about the human experience of the mind, heart, and spirit. So join me on this journey of in-depth learning about ourselves and the world we live in. Hello, everyone. We have a guest with us here today, a colleague and a good friend, speech pathologist Kane Casson. Kane is here to share with us about his work and shed some light on the mental health scene of speech pathology. Hi, Kane.
Hi, thanks for having me.
Thanks for coming. Can you tell us a little bit about what you do?
Sure. I'm an adult speech pathologist, and I'm actually currently working in two roles. I work in a hospital as an acute clinician, so we see the people when they're very sick or something has just happened to them. I also spend a few days a week working in a community-based rehabilitation team, and that is after the patients, or we call them clients now, when they've gone home, they've left their hospital or rehab facility, and they are getting more, they're back in their normal life at home, and we're to help them with any of their goals to try and get back to a quote-unquote usual life after something has happened to them.
So you have clients that are inpatient and outpatient clients. Is that what it is?
Something like that. In my hospital job, they are definitely inpatients. They are still in the hospital, sometimes still quite unwell. The ones I see in the community rehab that caseload, they have been discharged from the hospital system, and they're just trying to live their life day to days, but they still get a little bit of interaction from the healthcare system.
Okay. So do you see the clients in the hospital more often, or?
With my current contract, I'm 2 days at the hospital and 3 days at the rehab. But those are actually separate contracts. I just took on the two different jobs so I could have a full-time job and salary.
Yeah, that's a good idea. And you have like a sense of a different type of experience with both jobs as well.
Yeah, that's quite interesting because I get to understand the patient's whole healthcare journey almost, because when we see them in the hospital, it's when something has just happened to them. And in the community rehab, it's possibly their last interaction with the healthcare system before they're let loose into the world or
fully independent,
Perhaps, hopefully they're fully independent, but they are now not dependent on the healthcare system, or they won't be getting any further interactions from the healthcare system. That can happen sometimes.
Well, I was also wondering if the patients or the clients that you see in the hospital, you see them more regularly, as in like twice a week, or,
Okay, I'll clarify that a bit, because the speech pathologist, especially an adult speech pathologist, our main, what's the word I'm looking for? Like our caseload or our role is managing communication, obviously, as a speech pathologist. We also manage swallow because for whatever reason, the speech pathologist is a swallow expert. I guess that is because we use a lot of the same muscles and nerves and neural pathways as you do for manipulating your tongue to speak and communicate, as you do for when you're preparing food and chewing it up and about to swallow it down. So in the hospital caseload, a lot of the time we are seeing how people are going. Can they have food and drink safely? Because when someone has had a stroke or something quite severe has happened, sometimes you put food or drink into people's mouths and they're not swallowing it safely, and some of it's ending up in their lungs. And that can lead to pneumonia and all sorts of subsequent health complications. Some people never recover from a pneumonia. So in the hospital acute caseload, our primary concern is making sure people don't get a pneumonia, making sure food and drink is safe for them to eat. We're also paying attention to how their communication is going, and that could be many domains. It could be like a dysarthria, which means some sort of weakness of their lips or tongue or jaw. Imagine like a slurring. Imagine if you can't use if you're paralyzed on one side, of course you won't be able to make all the sounds and communicate as you want. Another issue could be your voice, and that's like when you have a sore throat and you talk like this, or you're smoking too many cigarettes, or something's happened to you, or you got laryngitis. So that's another role of the speech pathologist. And one of the more interesting ones is I say neurological linguistic differences. So that's actually thinking of words, thinking of words and understanding, like not just words, but like sounds, words, utterances, whole language. So we help out with that part, the actual part of communication, the part that starts in your brain, that begins with thinking of an idea and then transferring it into language. So I could communicate the idea I'm thinking via my mouth to your ears, and then you understand it. That's the whole language process. So with all those different things, there's a lot of things that could go wrong. And if one or more of those goes wrong, of course, that can lead to communication breakdowns. So in the hospital, we're primarily managing the swallow, but we're also monitoring the communication side of things. Usually when I see a client in a community rehab, their swallow should be pretty stable by then. It's a few weeks or months. It might be touch and go, or they might need new ways to manage how they're going to have food and drink. But it's really by then the person is really noticing that their communication is breaking down for one or many of those reasons, which I just discussed just now. So and when I'm in the community rehab, that's what we're monitoring them. It's what we're trying to rehabilitate. We're trying to, if there is some sort of deficit, we're trying to help the person get that back to a level where they are functional and they can speak or communicate with their loved ones or the people they interact with day to day.
Wow, that's so intricate. There's so many systems involved. And I guess they both, I guess the clients that you see in the hospital have different needs and different priorities from the ones in the community.
The ones in the hospital are usually, we call them acute patients. Like something has just happened, usually a stroke, but sometimes they've just been very unwell because of other reasons. Like they might have another illness which has led to catching a pneumonia for other reasons, or one virus or bacterial sort of infection has led to subsequent complications, which then might impact on the communication or the swallowing as well. But a lot of the patients in the hospital are a lot more higher need than the ones who are more stable enough to have gone home, and then they get their community rehab. And it's not just a speech pathologist who is involved. We also have the physiotherapist who is, for any sort of mobility, any muscle sort of issues, for people being able to sit, to stand, or also they could be experiencing pain. So the physio is involved with that. We have an occupational therapist, which helps with if the physio does the gross motor movements, the big movements, the standing up and walking, the occupational therapist does the fine motor movements, like the intricate ones, like using your fingers to manipulate a pen or to hold a fork or to type, these really small, precise movements. They also help with the arms. They help with cognition a lot as well. So thinking, memory, managing their fatigue, anything that might need to be done to exist day to day. Also, we have social workers, which are very involved in the mental health side of things, because we actually don't have psychologists on our team. But a lot of people, when something has happened to them, a stroke or any other sort of illness, and sometimes it might be as simple as breaking a leg. Like an old lady or an old man has fallen over at the bus stop, they've broken their leg, but that's had a huge implication because they're now completely dependent. So our social worker is the one on the team who helps with people who are having a difficult time managing with anything that's involved with since their event, but they can also help access services within the government, like for example NDIS or My Aged Care, or sometimes there are NGOs which help people at Meals on Wheels, for example, like accessing these services.
Right.
We also have a leisure therapist who's
leisure therapist.
It's true. Yeah,
what is this?
A leisure therapist. It's hard to explain. They are kind of an in between of all the other clinicians, I guess, but. I guess, for example, if someone has some sort of deficit after they've been sick, after whatever, they've broken their leg or they've had a stroke or had some sort of complex illness, the physio, for example, will help look at using those muscles to get them back. As a speech pathologist, if someone has trouble pronouncing words, we'll give them activities where they can use those muscles so they are able to communicate again, or they can practice thinking of the words that they want to say within a conversation. The occupational therapist might help them use their hands, so they can give them exercises so they can use that part of their body or use that part of their cognition or their brain. The leisure therapist is someone who tries to get the people doing the activities they were doing before, but by actually doing it or problem solving doing it. So say if, for example, someone's had a stroke and they have trouble using their right hand, and previously they liked doing some sort of activity like crocheting or knitting, and the occupational therapist might give them exercises to strengthen those muscles. But the leisure therapist will actually sit there with them and during the activity and try to problem solve the activity themselves. And the reason why they do that is because when people are motivated to doing the activity which you're interested in is a lot more motivated than doing a related exercise for that.
Yeah.
To make an analogy, if I love running, I love being outside, I love going up and down hills, I love seeing the dogs and the people, I love running. It's not the same if I just go to the gym and do the single leg exercises or both leg exercises which work those same muscles.
Right. Yeah. So it gives meaning to the recovery.
It does, yes. And the leisure therapist is, I guess, versed in all of our disciplines.
Oh, okay.
Yeah, and it gives them meaning as well. And sometimes I guess it's useful for the client who's having these difficulties to actually see how they go with the specific activity that they want to do. And sometimes if they have difficulty with it, they might have to pivot to a newer activity or change it to something else. Or they might need a little help problem solving.
Right.
How they can do that activity or something like it. Or perhaps sometimes you might need an extra pair of hands involved. But
there you go.
But yeah, the leisure therapist is an interesting role. I've never quite known how to explain it well, but it's someone who helps people get back to the activities that they want to be doing by actually doing that activity. So, for example, if I'm working with someone who has trouble communicating because they love going to the coffee shop with their friends and having a chat, I can do communication activities, but the leisure therapist would actually take this person to the cafe and have a chat with them. And from there, they can see if there's any other barriers which might interfere with working towards that meaningful goal.
It reminds me a lot of my time working with children who are on the spectrum and special needs. And I remember having to break down these tasks to teach them the tasks that we can do quite automatically. And, to like when to even stop pouring the water into the cup. How are they going to figure that out? With like, baby steps, as in like the line of where they can see, okay, I have to stop pouring now, and things like that. And how to gauge certain things, and how to lock the door or unlock the door, how we're supposed to like move our hands and twist and things like that, because quite a number of them have problems with fine motor skills, which is why I worked with an occupational therapist as well. But I used to remember it was such a meaningful event when almost day in day out you learn all these like small little exercises you practice with them in the house or in the room, right? And then it comes to a point where it's like a milestone, it's like a little graduation. We're like, all right, I think now we can go to the supermarket together, and I can confidently take the child to the supermarket with me, knowing that he or she will not trash all the things on the shelves and like start throwing things or start touching people. And then after that we graduated to going to restaurants where we can stand in line and actually do the things she loves. So it gave her like more meaning to behave, to I guess improve her behavioral their behavioral sort of capacities or abilities and things like that, and want to work on their skills so that they can actually take that into the real world and enjoy it. So that was really cool. So for some reason I thought of that when you talked about the leisure therapist.
Yeah, and I guess the leisure therapist helps to integrate all the other disciplines. And for example, if the overarching goal is for a person to go to the cafe and talk with their friends, there's a lot of things involved, just like you had broken down the supermarket or the restaurant goals. Yeah, like there's
huge.
Physically getting there, mobility-wise. If they need some sort of assistive mobility device, the occupational therapist might be involved. If the person has trouble standing up or down, the physio is going to be involved. They have trouble speaking and getting their ideas out, I'm going to be involved. So the leisure therapist would instead of looking at the individual components of that, they look at the activity as a whole.
And when you work in the community, do you partake in some of the activities or rather duties or obligations that the leisure therapist would do? Do you take clients out to
I have
the shops or something like that?
I think a lot of my therapy time is usually clinic-based, and we also go to clients' houses because a lot of people who have had strokes aren't allowed to drive. Sometimes it's for a few weeks, sometimes it's for the rest of their life. And you can imagine there's all sorts of safety reasons for that involved. Like if someone's vision isn't great, or their cognition, their capacity to make responsible decisions has been impaired. It's not just how you drive, but it's also reacting to what might happen around you. So part of our role, we're frequently going to people's houses, or we meet them halfway, or sometimes with some people we even do telehealth appointments.
Okay.
If they're agreeable, little by little people are getting more agreeable to doing the tele appointments, especially for the clients where I'm just doing a lot of talking.
Is that helpful, you find? Telehealth appointments for speech pathologists? Like, do you have to?
It can be. Okay. It depends on the client. I would find for those clients who are more mild to moderate and they have their cognition intact, I would find like telehealth would be suitable for them. Sometimes for the more complex clients, I find it's much easier to do that in person. But like, for example, if we were doing a therapy which was a bit more just about talking, for example, our social worker interacting with the client, or perhaps or it could be any of our clinicians who are having a more sort of educational, conversational appointment as opposed to a physical hands-on one. Like that's certainly an option. Because the client doesn't have to leave their own home. If when we visit people's in their homes, we need to arrange transport. There are government cars, but then when you have a dozen clinicians fighting for the same two cars, there's a lot of logistics involved. Yeah. But having said that, there's also logistics involved in even organising the telehealth. You think it would be simple, but then you need a computer, you need a room, etc. But it is a newer option, and it's certainly something that was not available a long time ago. For something like psychology, for example, where it is a very talky-based treatment, you can certainly do that by telehealth, and I've done that myself when I was having a rough time living in regional South Australia. I was living in this regional town, but I was having a chat to a psychologist who was in South Australia. Yeah, in South Australia, in Adelaide.
Okay.
Mm-hmm.
Oh.
So, yeah, it's certainly an option. And certainly during the peak of COVID, use of telehealth increased a lot.
Yeah. I've used telehealth as well in terms of counseling, and I'm still doing that right now because some places in the world, you just can't get out. You still can't get out. So they can't access their psychologists or therapists. There's some services that are still not up and running yet. And some clinics have actually shut down, so people are just really turning towards telehealth and Zoom quite a bit. So would you mind sharing with us what the majority of your caseload looks like?
I would say perhaps 2/3 or more of the time I am dealing with people who've had strokes. And yeah, strokes are complicated. Like when something happens to your brain, there can be a lot of things that can happen. But as a speech pathologist, and all of the clinicians are involved. And in the hospital, of course, you got all the different types of doctors, all the nursing staff involved. There's a lot of staff in the hospital, as you can imagine. We have a smaller team in the community-based rehab. But I would say a lot of the time in my role, I'm dealing with strokes. Of course, the physios would be dealing with broken bones a lot more as well. Yeah.
Okay. And what kind of clients do you enjoy working with the most, do you think?
I think I enjoy working with clients who are motivated and take agency in what they want to achieve. After you've had a stroke, for example, anything that our brain does can have deficits. So that could be how you use your lips and tongue to say the words. It could be using your hands or your legs to move about. And some of the more subtle things is how you think or how your memory is working. The complex tasks like you were describing before, to put your key in a door, there's all these little micro movements. And someone might be physically able to move their hands and arm in that, to physically move their hands and do that, but they can't plan the movements, they can't coordinate the movements to figure out what's the first movement, what's the second movement to achieve that goal, I guess. So, strokes are very tricky, and so I'm dealing with the more communications, less so with the swallow once they've left the hospital. But the clients I enjoy working with the most are the ones who understand they have deficits and they're motivated to get it back or to do whatever they can, and they put in their time and they're willing to work every day. Sometimes you have people who have deficits and they cannot speak like they used to be able to. They cannot communicate like they used to be able to. But they just don't make much effort. And that can be related to many things. It could be related to their personality and their values, who they were before this event. It could be related to their cognition and their planning, or how they view the world, because like something's gone wrong with their sort of executive functioning from the stroke. Perhaps some people, they just give up, or they feel sometimes they're highly depressed or going through an acute stage of grief. Some people have strokes, they get paralyzed on one side or one side of their body, or one arm or one leg, or there's a lot of physical things going on. Some people get very fatigued, like as the brain is repairing itself, their body might shut down for months and months, and they will just be so exhausted and tired.
Really?
Yes.
See, I've never actually considered that before. So they sleep a lot, or they just have no energy?
Both. So frequently people, they need to have frequent little rests throughout the day. Sometimes people, while they're highly motivated, they might be trying to do too much,
Right.
and they overwhelm themselves. And then if they overwhelm themselves on a Monday, they might not be good till Thursday after that.
Really? And so who supports them with that? Or is that something they learn over time by themselves?
On our team, the occupational therapist is the one who discusses and manages the fatigue a lot.
Oh, okay.
And to make the old analogy, you can lead a horse to water, but you can't make them drink. Frequently, we are providing exercises in our professional clinical recommendations to people, the things to help them manage day to day, but not always is that being adhered to, or sometimes it cannot be adhered to.
Yeah.
Often people have complex home situations.
Right.
Often they have complex health circumstances, which doesn't allow them to do the things we would recommend. Often there's a lot of appointments. And sometimes something completely external, like COVID-19 could happen, or who knows, like something completely out of the blue could happen, which impacts on someone's ability to do, quote unquote, the best thing or the most productive thing that would help them.
Yeah. Wow.
And sometimes people are very keen to get back to work. Sometimes they have children. Sometimes they are caring for someone else. So what in theory is the best way to manage their whatever's going on with their bodies and their lives is not always achievable.
Yeah, there are a lot of things grabbing this limited tank of energy and attention, actually. And I guess when you're struggling with your own physiology and your own psychology and cognition, there is less capacity to deal with the demands of the world and expectations of others.
Yeah. And since you just said psychology as well, a lot of people have low mood for a long time, especially after having a stroke, or sometimes even, like I mentioned before, breaking a leg or some sort of loss of previous role or ability. Of course, that takes it takes a toll on their identity, I guess.
That's true.
And a lot of people, just as they are recovering from their stroke, their mood might be different. Their ability to initiate, they might be depressed. They may or may not acknowledge that as well. So often we are, especially in my community rehab job, we are managing clients who are newly taking antidepressants and sort of going through that phase where their body's getting adjusted to the neurochemical changes, I guess.
It sounds like something happens and everything gets thrown out of whack.
Absolutely.
And jumbled up in the head. And then it's just this phase of this time of like trying to figure it out and save whatever that's
consolidate it.
And then just trying to make the best of it. And do you see any cases where, or have you had many clients where they've achieved almost full autonomy from before the event, or at least reach their goals to a satisfactory level?
Certainly. In my community rehab job, we don't get to see them for that long. Sometimes it's 4 weeks, sometimes it's 8 weeks, sometimes it's 12 weeks. And that's just policy, I guess, is what the government can afford to provide. Certainly with some clients who may have the more mild to moderate deficits, they're happy to get on with their life. They're 80 or 90% able to do what they were able to do previously, and they're happy with that. They're realistic. A lot of our clients are quite old. Some of them are quite philosophical, where they realize, like, if I'm in my 70s or my 80s and I can still see my grandkids and my family, that's still doing pretty good. Even if my speech doesn't sound the same, or even if I can't use my shoulders and my arms like I used to be able to, they find things which give them value and meaning and enjoyment out of life. Unfortunately, sometimes we do have really complex clients, and unfortunately, not much gains are made, and that can be these are usually in really, really complex clients with lots of comorbidities, lots of health issues going on. Sometimes there's environmental issues going on. We've seen a few clients who've come from overseas who don't speak the language, and then that adds an extra layer of complication. If we're trying to give cognitive rehab or linguistic rehab, like language rehab, but through an interpreter, it makes life a lot more difficult as well.
I can imagine. And you have a background in teaching language. So when you are faced with clients that don't speak English or don't speak English very much, how do you navigate this area, given that you do have, background knowledge in how the brain works with languages and your speech pathologist expertise?
I guess as both a former ESL English as a second language teacher and a speech pathologist, and also someone who's learnt a second language. I lived overseas. I learnt Spanish, and I remember what it was like learning that language or navigating day-to-day life when I was living overseas in a language that wasn't my native one. I was certainly capable, but I wouldn't say I was fluent. Taking all those considerations into perspective, just simple things like one idea at a time. Like right now, we are having lots of complex conversations and lots of complex ideas are coming out. But like if someone, for example, doesn't speak English as their first language and they've got cognitive, like understanding difficulties or memory difficulties, that might mean holding one idea in your mind while thinking about the next one. That might not be able to have... They might not have enough working memory capacity to be able to discuss multiple topics at the same time.
That's interesting.
Yeah.
I worked with refugees for a little while. Refugees who have suffered some traumas, and I remember having to work with them and a translator, especially the ones that don't speak English very fluently or at all. And with those who have had head injuries, documented head injuries, it was very interesting working with them because, from what you're mentioning, I'm just reminded that I remember having to actually, for myself, really break down the content of what I want to, content of what I want to communicate with them about on a piece of paper and make sure that I track that, because with the back and forth of the translators, the translating that was happening, I also have to make sure that they can only retain a certain amount of information, and I can't overwhelm them because that might re-trigger some traumas, and they might get re-traumatized, and that's when the amygdala is like flaring up, the PFC, the executive functioning part of the brain will shut down, and then they can't work with me anymore, and I need that part of the brain to be working, so I can't scare them I can't overwhelm them basically. So it sounds like you're trying to break down what is the core, most essential idea or theme that wants to be discussed, and spending your energy on that. And not going too far, not digressing, not getting excited. So I had to put it in a piece of paper just so that I remind myself not to overdo it with them. Because, it takes time and it's energy as well. Yeah, and certainly. And for example, at the moment, we are seeing a client who's very complex, who all of our interactions with this client is through an interpreter. And when I'm doing my speech therapy, I try to keep it one idea at a time. And I guess I've got the benefit of my linguistic education, being a former language learner and teacher, and speech pathology education. I understand that you can only talk about one idea at a time. But unfortunately, when I see the other clinicians working with this client, they're trying to have a conversation like we are having now, which is multifaceted. And unfortunately for that client, you cannot be speaking about multiple ideas about the past, the present, the future, all at once. First you're going to do this. You almost need to break it down. What are the 2 or 3 main things I want you to take away from this today, this appointment today, and write that down. And so they can refer back to it later. But even that's not always
it doesn't always help. For example, this client is just describing her vision, or specifically her perception, has been impaired.
Okay.
So even when it's written in her language, her brain's ability to understand, to recognize all the little individual squiggles and lines, and to recognize the shape of what the words they are, that's also impaired. So in these cases, we really need to work together. And we're all the clinicians. Every week I give a handover email, and for that client I just discussed, I am saying in bold, in capital letters, when speaking to this client, one idea at a time, full stop. Concept checked, full stop. Clarify if you're talking about the past, the present, the future.
And that's necessary. It's so necessary.
And that's something we're taking for granted. If we're talking about, so you had this accident, it's affecting your life in this way today, but in a few weeks you're going to see a neuropsychologist. There's quite a few concepts are going on right there. And for someone whose memory is absolutely shot, she's not going to walk away from that conversation with all those complex ideas.
Yeah, so you're a bit of a mediator as well.
Sometimes.
Like a spokesperson,
I guess,
for the client's abilities.
Yeah. And also, like, the occupational therapist might take a similar role when it comes to cognition or it comes to memory, for example, or fatigue as well. So often we try to see a client when they come into the clinic. We might try and get 2 appointments for that visit, just to get, because it's easier to coordinate 2 visits than 3 visits, for example. But that having the client see 2 clinicians for 1 hour each, it could be physically or emotionally overwhelming. With the speech and the occupational therapy, we are often doing a lot of cognitive or linguistic sort of rehab. It's emotionally draining.
Yeah.
You know, when you're trying to cram and when you're trying to study and you're trying so hard.
You're struggling.
So imagine going through an hour of that, and then you have to go do an hour of something similar but different.
Yeah. It sounds really draining. And I'm wondering what you do when you experience clients who are having a bit of a during the session or who have come from a different session into your clinic, who are struggling emotionally or psychologically in terms of their abilities. How do you manage that? If
it's too much for them one day, some days you might just have to cut it short.
And how do you pick up on when those days are going to be?
Hopefully I'd be able to pick up on it. Like
what are the cues?
Body language. Sometimes they will tell you. Sometimes they'll have blank looks on their faces, or just more processing time, or they'll just start nodding and smiling and not really engaging. You know, when you're having a conversation with someone and they're sort of not quite present, like that can happen. Or they might get a bit grumpy, or they just might not want to interact. But hopefully, like, these are little things that you notice for anyone when they're a bit tired or grumpy or overwhelmed, or they might get a bit more emotional. They might not react in one way you would expect them to.
Do they get upset?
Yeah.
And how do you deal with that when they do?
Try to have a bit of empathy, acknowledge how they're feeling. Like, this is frustrating. I know you've gone through so much. Remember, a lot of these people are going through pretty acute phases of grief as well. Like perhaps just even 2 months ago. Some of them might be young enough, like in their 50s, for example, and they were the main breadwinner for the house. Some of them come from highly powerful positions. Perhaps they were in managerial positions in their companies. And they've gone from being the main breadwinner, being a parent, being a problem solver, someone who's respected, and their whole life is transformed. So now they are perhaps completely dependent on others. They are unable to complete basic things, like opening a door or getting up or saying hello or I love you to someone you care about. Like little things that we take for granted. Any or all of that could be taken away. So in those cases, like, the best thing to do, or I hope it's the best thing to do, to acknowledge their feelings. And like I say, I understand this is frustrating. Is this too much for you today? How about we leave it for another day? How about I give you some tasks that you could do when you're feeling better? Something else I do. Ideally, I would love to have my clients doing several hours of speech therapy per day. But the reality of they're not going to do it. Yeah. It's tedious. Some people would do it occasionally, or they'll do an hour or 2 hours. You know, like some people might study for a few hours a day. Yeah, and they're happy to do it, but others will just drag their feet and not want to do it. I try to start at a bare minimum. Like, could you do 5 minutes? Yeah. Could you do 10 minutes? Could you do 20 minutes? Or if I split it up into different tasks, and I try to, if I told someone I want you to do 2 hours of speech therapy a day, it's not going to happen. Yeah. But if I serve it in achievable chunks, like could you do 15 minutes in the morning, 15 minutes in the afternoon? That's all of a sudden, it's not so overwhelming. And it's empowering once you achieve 5 minutes, and then you go like, I can do 10. I can do 6. Yeah, exactly. Yeah. So that's a pretty good psychology trick behind trying to get people to do their tasks and their practices. With counseling, we do the same thing. If we have homework for clients, sometimes depending on what the case is, we do the same thing. We're like, maybe it's a good idea, when you need to encourage them to have better self-care practices or start something new for themselves. So it'd be like, all right, just go for meet someone socially at least once a fortnight. I mean, that might be daunting for some people, but once they achieve that, they're like, okay, maybe try once a week or something like that. Or meditation, try for like 5 minutes a day. And it doesn't sound so scary. It sounds doable. And I take a similar approach. Like, for example, if someone can only do 5 tasks, or if the goal is to do whatever the task could be, but if they're only getting one of the 5, that's all right, we got 1 out of 5 today, let's try it again tomorrow and try and get 2 out of 5. So the same micro incremental approach, I find I use a lot. And I try to remind people, like, perhaps today we can only get 1 out of 5 of whatever the task is, but perhaps next week we might get 2. And I've constantly tried to get the clients to remember how they were when this first happened. Because some people, when they're in hospital, they literally cannot communicate. They cannot understand language. Wow. They might be getting food through a tube down their throat or in their belly, or they might be eating mushy sort of food because they've lost their ability to chew and swallow safely. So they're giving them baby food, for lack of a better word. We call it pureed. Or like highly sort of thick and
the yummy Heinz jars.
Yeah, lots of things like your yogurts and your custards, etc. But it's not like eating a steak and chips. But still, like, obviously during that very acute phase in their recovery, it's quite traumatic, of course, like they're quite helpless. But I do remind people that, you remember how you were a few months ago versus now? And that might be like light and day. And whatever that time period is, like, imagine how you're going to be in 2 months more. Right. So try and keep that hope alive. Like, try and give them some meaning. Yeah. And another thing I do is, this is throughout the service, we try to work on goals which are meaningful for the client to do. And we're constantly negotiating, like, what can't you do now? What gives you trouble? What would you like to work on? So it's sort of going back to that discussion we had about the leisure therapist. Like, what's something you would like to do? And sometimes it's really vague. Sometimes it's very specific. Sometimes, like, communication-wise, like, if it's very specific, like, I want to have a conversation with my friends at the coffee shop, and perhaps they can't talk like they used to, but they can still interact. So we can help them with little phrases or like, even little things like nodding your head, showing your interest, giving eye contact, little words you can do to help them participate. Tell me more or something like that. I'm listening. That sounds interesting. Sometimes people, their goals are very vague. I just want to talk good. But that might be very multifaceted.
Right.
Does that involve how they are paying attention? Does it involve them being able to understand? Does it involve them being able to say the word? Does it involve them being able to think of the right word? Does it involve them being able to understand complex or abstract ideas? So
that can mean so many things.
It can be, yeah.
And how do you figure that out?
We've got the education, and I guess we go in there, we, like Sherlock Holmes, we try to look at the person's presentation, and there are models and theories of the mind. But as I'm sure you're aware, in counseling and psychology, like the mind is marvelously complex, and there's certain things you might expect, certain things you might not expect, and then there's, just to throw a curveball into the mix, things like just a person's personality or their values as well. So
I wonder what the mental health predispositions of certain clients that you get look like prior to the event, for those who are motivated versus those who aren't motivated.
It certainly plays a role. A lot of people have stroke or illnesses which are due to lifestyle. For example, obesity, drugs, alcohol, uncontrolled diabetes, etc. Unfortunately, if you're not looking after yourself, you're more likely to get sick. And if you're not looking after yourself, like, why are people not looking after themselves? Is it because they were never educated, because they don't believe they are worth it? Who knows? So, and on the other token, sometimes you can have marvelously healthy people and something horrible. They can get hit by a bus, or they could have a stroke. They can grow a tumor. So we do see a difference between, for example, the person who has had a lifestyle influence event versus someone who's just had something unfortunate. And as socioeconomic might play a role in this, not exclusively, but it certainly could. Like socioeconomic, education, and in the environment in which they were brought up before. So, for example, if something has happened to this very highly functioning sort of member of society before, usually they are really motivated to get back, and they will do whatever it takes. Not always. I am overly generalizing here. But sometimes if you've got someone who their poor choices in lifestyle has led to this event, it's almost like they might not think it's worth the effort. Or they may not think they are worth the effort to do this very difficult thing. Rehabilitation's tough. And so for some people, it might, doing the same task when they were, before they got very sick, it might have been overwhelming for them anyway.
That makes sense. I mean, if someone struggles with self-care, they are more likely to struggle with rehab. And I suppose I'm also wondering, for those who may have had an okay lifestyle before, or maybe not great, but passable, and then the event happened. Have you ever seen cases where there's a bit of a shift, and they're like, you know what, I'm going to get my life in order?
We certainly have seen that, and that's quite heartwarming, actually, when someone, when they realize, like, shit, I was not controlling my diabetes. I was not looking after myself. I was eating all this rubbish food, or I was drinking too much.
It's like a turning point or something.
And they realize, perhaps, when people are in the hospitals, during the acute phase, they're quite helpless, or they're very dependent. That's why they're in hospital, right? Because they need the help of others to survive. It could be for medical or other reasons. And some people use that event as a fork in the road, and it makes them realize what's important. my children, my family, or doing something meaningful.
Yeah.
Could be walking the dog. Could be watching the Broncos lose. It could be something like that. But for some people, they certainly do use this as a turning point, and they realize if they continue as they were, perhaps they're only going to have a few more years of life, as opposed to they might have 20 more years of life.
Right.
So that's certainly what a success story, which we do see sometimes.
Okay.
Unfortunately, we do also see sometimes perhaps they left it too long as well. But you got to take the good news when you can, right? And,
Yeah, thanks for sharing all of that, Kane. Before we end our podcast today, I was wondering if you'd like to share with us how you manage yourself and self-care when you deal with such cases where your heart goes out to the clients and you're feeling really empathetic, because some of them does sound really heartwarming or heartbreaking.
Yeah.
How do you manage that as a practitioner?
I would call it just general self-care. You know, the stuff that we're supposed to do. Exercise, sleep well, socialize. If you're having a bad time emotionally, talk to your mates or talk it over with someone. I'm pretty good at not taking work home related to the clients, I guess, or the patients, because that's just constantly getting turned over. And of course, sometimes you get a heartbreaking story and it might leave you a bit down for a day or two, especially when someone gets ill. People die sometimes, especially in hospitals, they can die at any moment. Sometimes in rehab, when you think they're getting better, there can be another moment, and we all sort of take that a bit badly for a day or so. But at the end of the day, it's the job, and we wouldn't be doing it if some people can't hack it. Some people, they decide they'll get the qualification, but they might prefer to work with children or in a happier sort of environment. I certainly think there are different sorts of personalities which are more suited to be working in the adult caseload. Yeah. And I think those ones probably need a bit of resilience. And it would benefit them from being able to self-reflect on how they are feeling when these things happen. And the healthcare system, whilst it has its shortcomings, is pretty big on monitor yourself. Like, we have supervision, which is like we speak to a mentor, someone who's more experienced. They encourage psychological input as well. During COVID, the organization I work for, they offered 6 psychological appointments for people going through a rough time, because as you remember, it was kind of terrible for a while and we were completely distant and isolated. But to answer your question, how do I deal with these emotional burden? I guess I exercise. That helps me a lot. When I exercise, I sleep better. I feel better.
It's all the endorphins and serotonin.
Exactly. Yeah. I feel better. I probably walk with my shoulders back and my chin up a bit higher, and perhaps with a bit more cockiness in my step.
and I've seen that in you, so I believe you. You're not making this up.
Yeah. Exercise helps me a lot, especially if I'm really stressed. It's just a chance to blow off that steam. I also try to sleep. You know, I know we're supposed to sleep 7 or 8 hours. Sometimes I stay up too late on my phone, but like in the background, that is a goal to get good sleep, because I do notice after a few days, if I don't sleep well, my performance drops. I get snappier.
Really?
Yeah, wow. And just cognitively. Like, sometimes with people's healthcare, there's a lot going on and we need to have our wits about us. Yeah. And we need to be able to write reports using all those fancy, schmancy psychological...
You have deadlines as well.
Yeah, and when you're sort of under pressure, like, if I haven't slept well for a couple of days, that whole process is a lot more difficult than it needs to be. So I try to sleep, I try to exercise, I try to eat well. Like things like alcohol. Like I used to drink a lot when I was younger. I'm pretty good with it nowadays, but simple things like don't drink a bottle of wine on a school night. Or if...
Wise advice.
But that's just something through my own little journey I've noticed as well. If I am feeling shitty and overwhelmed, it's a lot more productive to go work out for an hour than it is to drink a bottle of wine.
Yeah. And you can do that when you come over and we hang out.
Yes.
On a different day.
But I try not to take stuff home. Sometimes we do, but just the general self-care.
And it sounds like you have an internal monitoring system where you know when you could use more sleep, or you know that you need to do more physical activity, or you know that you're impacted.
Yeah. And I guess a benefit of this job is we are frequently telling people to do all that stuff I just described.
This is true, right? So practice what you preach. A client I saw yesterday, we probably spent about half an hour just even talking about how's her sleep, how's she eating, is she drinking much water? That's not my role at all on the team. That's just common life advice, right? But this client, her cognition is severely impaired, like the ability to sort of to understand those causes and effects. Like if you don't eat a lot, then you don't have energy, and if you don't have energy, you're going to feel rubbish, you're going to feel lethargic, and that it might lead to... There's probably a depression going on also. And if you're feeling lethargic and you have no energy, you're not going to be able to participate in your rehab. If you don't participate in your rehab, you're not doing anything meaningful. You can see how it's all... Do you draw? Linked. Do you make it visual for them?
Sometimes. Yeah. Sometimes, I guess. Yeah. But sometimes we are just telling these basic sort of things.
And it sounds basic, Kane, but like we often take them for granted and we overlook them because, I can catch up on that tomorrow, or I'll just, go for a run on the weekend, but we in the days or the hours until we get around to sleeping better, or, exercising more or eating better, we just deteriorate. We just keep deteriorating, hoping for that weekend to catch up on everything, but why put ourselves through that next few shitty days when you can just kind of perk yourself up a little bit and steadily cruise along until the weekend so you can actually have a good time.
You want to enjoy your weekend, not just sleeping.
Not recover. Thank you so much. Do you have any key takeaway messages for our listeners?
Especially in regards to my rehab goal, you got to find something that someone's interested in. It's got to be meaningful for them. I'll leave it at that. Just if it's meaningful for them, I guess in the bad old days of healthcare, doctors or clinicians would say, righto, you're going to do this. That's because that's what I, as an authority figure, are telling you to do. Yeah. And you'd probably know...
It's extrinsic, it's not intrinsic.
Yeah, exactly. And I'm sure you would be more aware. I don't know, you can tell me, like, is there literature relating to when someone is doing something that they want to be doing, that it's motivated to do, that it's meaningful for them, they're more likely to do it?
Yeah. Of course. Like certain parts of your brain light up when there's purpose and meaning involved, and a lot of that has to do with when the purpose and meaning is actually associated with other people. So in some form of benevolence, or children, family members, friends, partners, and things like that. So when the meaning is associated with some sort of social association or giving or compassion, then the meaning and the purpose tends to stand for longer. They tend to be stronger. And sometimes we can feel motivated. We can feel like this is a good purpose. It's quite meaningful. I'm gonna channel my next few years of my life to do this for whatever reason. But it might not be solid enough in that sense, where you you can continue to pursue it even when you get a few hits or obstacles. You've been knocked off the road a few times. Sometimes just like, no, what, screw it. But if there are people involved that you want to help or be part of, and there's love and compassion in there, you are more likely to get up and get back on that road, even though it's so hard. So, yes.
Yeah. Oh, wow.
To answer your question. What about for people who have or who know of people who've had accidents or experienced strokes, had certain, aneurysms and things like that, people that end up being your clients, their friends and family members, what can you tell them in terms of how to expect their responses, how to expect their abilities, and how to expect their mental health?
Yes. Could you repeat the question a bit?
Okay, so basically, sorry about that.
Yeah.
Maybe it was a bit convoluted.
Yeah.
So you have the family members.
How the family members' mental health might be impacted? Or?
Maybe that is a good thing to talk about as well, but also just how they see the patient or the client, what they should consider. Because sometimes people don't see what's going on. All these things you've talked to me about, they don't really occur to someone immediately when they, when they see their friend or family member after a stroke. Like I know I lived with my grandmother who's had 2 strokes, right? And she also had dementia and schizophrenia. So we work with what we see at face value, but in the mind, especially when you're younger, you don't know, you don't have the education, you don't know what it's like for them. So you do the best in terms of like being compassionate and caring, but you do get frustrated, this and that. So how do people cope with that by putting themselves in the patient's shoes?
This is tricky, especially if the patient's with dementia or some sort of cognitive decline or perhaps some sort of executive functioning deficit in their brain. Like the partners don't understand, why does he keep doing this? Or they don't understand, we've talked about this 1,000 times. And as a clinician, sometimes our role is to educate family members that this person cannot think like he used to, or his initiation, his ability to get up and do something, his ability to understand cause and effect, consequences, it's impaired, or their ability to see from the perspective of how someone else might feel might be impaired.
That's true. That's another part of the brain as well.
Yeah, and sometimes we have to provide that education. Like the family member, the husband and wife, they just might understand it. My husband or wife is being a jerk.
Right.
On the surface, yes, but like when we look into it, we sort of, all right, this part of the brain was damaged, and with that, we might expect X, Y, or Z to happen. I suspect that something might be impaired. It could be memory, it could be initiation, it could be some sort of executive, it could be their ability to understand complex ideas. And trying to help the family to understand those deficits so that they don't get an emotional reaction. Of course, it's still frustrating no matter what.
Yes,
yeah,
for sure.
But giving them the knowledge to understand how it is. So it's more complex than he's being a jerk.
Yeah.
It's sort of taking a neuropsychological approach. It's like this was damaged and this is the effect, and this might explain this behavior, and it almost sort of humanizes it a bit. Like if someone lost a couple of his toes, of course he's gonna
be running soon.
Yes. And I find getting that information it can be beneficial, and when the family members understand that, it almost gives them permission to be a bit more forgiving.
Yeah,
or
and
it's
relief as well.
Yeah, it's not a personal thing. You would hope, but if that was happening, I'd try and get the GP involved. GPs are involved all the time through both of my jobs. They're like the case manager, I guess. Like when someone's discharged from a hospital, like the GP gets a discharge summary and they follow up and they help decide how we're going to manage this client. Well, what else is going to help this client? And it could be a referral to a service like community-based rehab, or getting a NGO involved, or getting a psychologist involved. I sort of hinted before that sometimes it's not just the person who's been ill who has mental health effects, but also the family. Yeah. Maybe they've lost their role as well. Perhaps they are now seeing themselves in a capacity as a carer. Yeah. A carer of someone who's dependent, and taking the client to all the appointments. Yeah. If someone's having like troubling behavior, kind of like we were just talking about a minute ago, that stress and that burden can really build up and take an effect on the carer as well. So GPs are involved with not just looking after the person who got sick, but also the greater family, getting mental health involved, getting counselling involved, social work. So my recommendations would be, try to understand what the deficits are.
So the lost perspective.
Basically. Yeah.
What the person can't do anymore.
Or what they might need help with. Get help from the GP. If you're having a rough time, get the GP involved. And they're trained. They go to medical school for all these years and they get paid a small fortune. Use their services.
They know a thing or two.
You would hope
Trust
so.
them, hopefully.
Yeah. And if you don't like what that GP said, go find another one.
Exactly. Second opinion is always recommended. I think we should probably wrap up soon. Thank you again. Thank you so much for your time. It's been fun. I've learned a lot. I mean, I've known you for a few years now, and I've heard you talk about these things, but just sitting here and hearing you explain everything, just listening, I'm learning so much more, and it's been awesome.
Thank you.
And thank you for sharing this space with us here on Science of the Soul.